Thank you for inviting me to come back to talk to you guys. It's been a year since I was last here, and it's been a very exciting year. So thanks again for coming and for inviting me. First, we'll kind of go over a little bit about the stem cell transplants, what a stem cell is, and what the process is for transplantation, and then we'll open it up to some of our patients that have experienced it. So sickle cell disease is a global problem. We know that it affects thousands of people, millions of people around the world. And this kind of highlights that it's a global problem, but it's usually concentrated in the malaria endemic regions. And in Africa, Middle East, India, there are thousands of people that are born with sickle cell disease every year. And we also see thousands of people also born here in the Americas and in Europe. So it's a global problem, and we're trying to find solutions to help this disease. What happens in sickle cell disease is you have a round red blood cell. And under certain conditions where you have low oxygen or if the red blood cell gets dehydrated, you know that the red blood cell sickles. And this causes the red blood cell to release toxins that could be harmful to the body. It causes it to damage the blood vessels. It can cause anemia, and it decreases the blood flow in the blood vessels. And all those problems cause injury to the patients from head to toe. And it seems like almost nothing is spared. You can have strokes, eye problems, heart and lung problems, kidney problems, and the big complication that most patients have is pain. A lot of different people have tried to see what defines aggressive sickle cell disease, and things that might predict who's going to have more problems down the road. And here are some of the factors that have been associated, and a lot of them are things that we saw on the previous slide. Things like heart and lung problems, kidney problems, having acute chest syndrome. Some other things that they've noticed is people that have a low hemoglobin F might be at higher risk, or a higher white blood cell count, maybe reflecting that you have a lot of inflammation going on. So what are the current therapy options that we have available? We know that infection is a big problem, especially the bacteria that causes strep, like strep throat. That same bacteria often causes pneumonia. It's the #1 cause of pneumonia in America. And with penicillin treatment in children, we can reduce the rate of infection by 85%. And with the Pneumovax, the pneumonia vaccine, every 5 years, that can help reduce the risk of that strep pneumonia infection by about 70%. Other things that we have include hydroxyurea, and this reduces the rate of pain episodes, acute chest syndrome, and it can help decrease the transfusion requirements or improve the anemia. It's also been shown with this longer follow-up that it can also help people live about 40% longer, but not everybody tolerates hydroxyurea and not everybody responds to hydroxyurea. And the other treatment that we have available is chronic transfusion therapy. This helps, there's very good evidence that this helps prevent a primary stroke from happening, and if you've had a stroke, this can help reduce the risk of another stroke from happening. It may also help reduce the rate of acute chest syndrome and pain episodes, but chronic transfusion therapy comes with a bit of a burden. One is that the iron in the red blood cells accumulates over time, and that can cause injury to things like the liver, possibly to the heart. Also, eventually people are at high risk of developing antibodies where they recognize that these red blood cells aren't their own, and they get this thing called alloimmunization. And this can happen up to half of patients. And then finally, there is a small risk of infection, but over time you do kind of have that concern also. And so with these therapy options, we have improved the care for sickle cell disease. But what we've been trying to work on is something that might help alleviate the sickling of the red blood cells and the syndrome in total. And that's where stem cell transplantation has found a role. So what's a stem cell? A stem cell is a cell that can mature into a specialized cell type, or it can self-renew to produce more stem cells. So if you have a stem cell here on the right, it could replicate itself and produce more stem cells so that your body would have an adequate supply. But it could also turn into white blood cells, platelet cells, and red blood cells, which is the goal of stem cell transplant in sickle cell disease. We want to have these round red blood cells be produced continuously by these stem cells. They live in the bone marrow, which is kind of that brown area inside of a bone if you've seen inside of some of the bones in food. And if you look at the picture on the right, that is millions and millions of cells that are being produced every day, and they get circulated into the bloodstream continuously, just keeping our blood counts up at a safe level. So the stem cell lives in the bone, and it's anchored there by certain bonds with the bone. And you have different ways of getting the stem cells out of the bone marrow. Originally, what we used to do is bone marrow biopsies where the patient would go to the operating room, the donor would go to the operating room, and they would have the biopsy needles put into their hip bone, and then the bone marrow would be extracted with syringes, and it would be collected in a bag. The newer therapies involve breaking this bond that keeps the stem cells in the bone, and then it helps the stem cells go into the circulation, and then the donor can come to the donor room after 5 days of receiving an injection and come to the donor room. They get 2 IV lines placed, and then they collect the stem cells. The blood goes in one IV, it gets spun, the stem cells get collected, and the rest of the blood returns back to the patient. Usually takes about 2 hours for the donor, and it's again 5 days of injections, and then on that 6th day they come into the donor room to donate their stem cells. The injections often have very mild side effects. The most common one is bone pain, because the stem cells are getting revved up to produce extra stem cells, and they're also getting released into the bloodstream. So they might get a little bit of mild bone pain as the most common symptom. When we try to get stem cells, we want to make sure that they're matched, though. And we match based on 2 different things. One is the blood type, and that's, if you're A positive or O negative, that's one thing that we match people on. But we also match people based on their HLA type. And that's a very unique fingerprint that all of our cells have. That's what tells our body whether the cells belong in our body or whether there's something foreign like an infection or a virus or bacteria. We have 2 different sets of these HLA fingerprints. One comes from the mom and one comes from the dad. And here's kind of a schematic of the HLA types. So here father has type 1 and type 2 of the HLA set, and mom has 3 and 4. So the father will pass one of those 2, either 1 or 2, to the first child, and here they pass on number 1, and then the mom would pass on either 3 or 4. So in this case, she passed on number 3. And then the same goes for the second and third child. So the father passes on one of those sets, and the mom passes on one of those sets. And so what you'll see is the first and the third child both got the same sets. And so they would be a match. They would be able to donate stem cells to each other or receive stem cells from each other. And the chance of having a match in brothers and sisters with the same parent is about 1 in 4. So each brother and sister have about a 1 in 4 chance of being a full match. So the first bone marrow transplant was performed in 1984, and that was in a patient with sickle cell disease who also had acute myeloid leukemia. And this was originally a therapy that was used for a lot of the cancers, the leukemias, lymphomas. And what they found was they were able to cure both the leukemia and the patient of sickle cell disease. And this was very encouraging, and people have tried to develop therapies on how to apply this to people with aggressive sickle cell disease. And so far, actually over 450 people have been transplanted thus far. The majority of them have been in children less than 16, and the majority of them have been in people who've had a matched brother and sister. As a kind of overview of the chemotherapy-based regimens that have been used in children, these are very high doses of chemotherapy. What they've seen is that you have about an 85% success rate, or being sickle cell free. About 9% of the children have not taken the stem cells or rejected the stem cells. And then the other complication has been this graft versus host disease. Graft versus host disease is when the stem cells that are donated into the person aren't happy, and so they cause some inflammation, and they might cause a rash, they might cause some lung irritation, they might cause the eyes or the mouth to be dry. That's graft versus host disease. Sometimes it gets better on its own, but sometimes you need to give a medication or 2 to help cool it off for a little while. And that's been seen in about 15 to 20% of these intense chemotherapy regimens. So about 1/3 of sickle cell patients fit these criteria to have severe sickle cell disease. And we'll go over some of the criteria in a few slides. The problem is that of those 36% patients, only 14% are going to have a brother or sister that's a complete match, that doesn't have sickle cell disease as well. Some other sources of the stem cells include getting stem cells from an unrelated donor, and that's in the worldwide registry. And the chance of finding a perfect match in that worldwide donor pool is about 1/3, or 30 to 40%. They have tried these regimens in a couple of patients, and they're still trying to figure out the right treatment regimen to help increase the success rate. The other source includes cord blood cells, and that's also something that's still in studies right now, where they're trying to figure out the right regimen to safely do this. And then finally, something that is getting us a bit more excited is haploidentical donors. And this is when you have a relative who has half of those stem cells. So if you remember those different HLA sets that we had seen on that previous slide, if they had one of those two that were the same and they were still a relative, that's called a haplodonor. So in adults, we've tried to apply the same intense chemotherapy regimen. We found that it's too toxic. The chemotherapy is just not well tolerated. It can cause problems to the kidney, to the liver, to the heart, to the lungs. Also, patients have a higher rate of that graft versus host disease. So that taught us very early on to back away from the intense chemotherapy. Then they tried some reduced regimens where they just tried very, very light regimens, and they found that it was too light. The body wasn't prepared properly to accept the stem cells. And then more recently, we've learned to target the rejection cells, just to try to cool off those rejection cells to allow the donated stem cells to get comfortable and start making some more round red blood cells. And so first they tried a medicine called ATG, where they started to see some success. And more recently, there was a medication called alemtuzumab. And this is the medication that we use here to help try to reduce the rejection cells from causing rejection of the donor cells, the stem cells. Alemtuzumab is an antibody that binds a specific protein on white blood cells, which is called CD52. And the cells that have this protein, CD52, are very important in the rejection of the donated stem cells. These cells also do have an important role in our body, and the primary role is to help us fight viral infections. So when you get this medication, we have to be very vigilant to make sure there aren't any viral infections. And we do a blood test to check for CMV, which is a specific virus that can sometimes go up with this medication. So this study from the NIH in 2009 was a breakthrough for the treatment of sickle cell disease, where it offered stem cell transplantation to people with aggressive sickle cell disease in adults with a very high success rate and a very low toxicity rate. And they've done, what they've reported last year were 23 patients so far. They've expanded it to 30 so far, but we're still waiting for them to present the data. The age range is from 17 to 64 years old. So they are able to, the people that are a bit older are able to tolerate this regimen still and do pretty well. All 23 patients are alive. The longest follow-up is up to 8 years now. And 20 patients are sickle cell free so far. So it's about an 87% success rate. So this is similar to what we had seen in the children. They saw two people that developed chickenpox reactivation, which is a type of virus. And they saw two people who they had to be put on a virus antibiotic because that virus, the CMV virus, started to go up a little bit in the blood. So they were treated preventatively for that. But what was very impressive was that no patients developed that graft versus host disease, which was seen in about 15 to 20% of patients with the intense chemotherapy. So here at the University of Illinois, we are also trying to see if the findings that they had at the National Institute of Health hold up, because sometimes in specialized centers, we know that you may get different results. So the goal of our study here is to see what the success and complication rates are for stem cell transplantation using this regimen, to see how we could improve the complication rates of sickle cell disease with this kind of bone marrow transplant, and most importantly, to see how well we can improve the quality of life, which is something that Dr. Su had suggested, which is, I think, a very important part of assessing the role of transplant. So the inclusion criteria, a lot of these are things that we had seen before, things that define aggressive sickle cell disease. And these include things like having frequent pain, having strokes, having 2 or more episodes of acute chest syndrome, developing antibodies, the thing that we had talked about that develops in up to half of people that are continuously transfused. Having eye problems, avascular necrosis in the hips or shoulders or back, having kidney problems, and lung and heart problems. And what's important is some people might think that they're too sick, but you actually have to have some problems to kind of predict who's going to be aggressive. And it's important to just, if you think you should be evaluated, you shouldn't think that you're too sick and kind of write it off. You should see if you are still eligible for transplant. This is the regimen that was used in the NIH and that we use as well. It's a 10-day preparation regimen. And it starts off with the red blood cell exchange. That's on day -10. We count backwards from the day the stem cells are infused. Then we make sure that people stop hydroxyurea because that could potentially affect the stem cells. And then we give the medication alemtuzumab over 5 days. And the first 2 days are test doses, and that's when people actually have, they may have a reaction where they might get chills or shakes to it because it's a protein that your body is getting used to. So that's why we do test doses to get your body accustomed to it. And then we give the rest of the medicine divided over those other 3 days. You get a small dose of irradiation on day -2, and that goes to the centers that are also rejection centers, the lymph nodes. And then the stem cells are, you start sirolimus on day -1, and that's a pill that you take, which is an anti-rejection pill. And that helps your body accept the stem cells, and it also helps keep the stem cells happy in your body. And you take that for a year until the stem cells are stable and your blood counts are stable. And then the stem cells are infused. And the stem cells go back into your body just like a transfusion. It takes about an hour and a half to 2 hours. But usually we give pre-medications beforehand, and people usually kind of either sleep through it or we try to kind of relax them through the infusion. So currently we've transplanted 4 people so far. The side effects that we have seen, one person developed antibodies. They had gotten exchange transfused and developed new antibodies. And so we had to hold the regimen, let everything cool off, and we repeated it without the exchange transfusion. 2 people had fevers or infections, so they had to be readmitted to the hospital. But we have not seen that bad virus, the CMV virus, get reactivated, and we have not seen any signs of that GVHD either, similar to what the NIH experience has been. Here are the hemoglobins. I don't know how well they portray here, but the red lines are the normal ranges, usually between 12 and 15. And most people started between, probably between 7 and 9 and are doing pretty well. This is the sickling number, the LDH, which tells us how much red blood cell breakdown is happening. If you can see it, the panel on that left is in the thousands. So some of these peaks are during very high levels of red blood cell breakdown. And they've all come down pretty nicely down into that normal range as well. And this is one of our favorite figures, looking at the hemoglobin A, or how much round red blood cells are present. And the people that have been transplanted with people that don't have, who don't have sickle cell trait have had hemoglobin A's in the 90s. And then our one patient who had sickle cell trait has a hemoglobin A in the 60s, so he's been turned into sickle cell trait. So as we mentioned before, about 14% of people have a suitable or a matched HLA donor. And that kind of limits how many people we can transplant and how many people we can offer this cure to. So the other direction could be looking in the bone marrow donor registry, where there's about 30 to 40% of donors that may be a match. And those are regimens that are in development. And then the thing that has us most excited is this haploidentical transplant, where you have a relative who's a half a match. And this is based on a recent report of 14 people that received a milder chemotherapy and received these half-matched stem cells from a relative. And they found that all 14 are alive, with 8 of 14 successfully accepting the stem cells. So you're about a 60% sickle cell-free survival. One person developed a mild rash that got better, and nobody has developed long-term graft versus host disease. So this regimen probably needs a little bit of modification to try to improve that success rate up from 57%. But what we're happy to see is that it has had very limited toxicity. There haven't been very serious infections, and there haven't been very serious graft versus host disease problems. So of course, this has been a huge endeavor. And we'd like to thank most of all the patients and the donors who've gone through this, the transplantation. We'd like to especially thank the nursing staff up on the bone marrow transplant unit, the transplant team, and our sickle cell team.